Oh, hi. Welcome, everyone. This is Dr. Sam George, one of the ITU anesthetic consultant, George Elliott, ITU lead. And this is January 2025. So happy New Year to all of you and wishing you a great new year. So this topic is all about approach to a deteriorating patient. And we'll try to learn the essential skills. And obviously, this is meant for foundation years, SHO, house officer, final year medical students. So it's all about recognizing, assessing, and managing clinical deterioration in acute care. So let's see if it works for you. So learning objectives would be to recognize the signs of deterioration, have a systematic approach, to have an approach to diagnosis, develop a clinical management plan, then support and escalation as appropriate, and maintain continuity of care. And that's what we'll be doing. So, News 2 score, I'm sure all of you are aware of this now. And this scoring system monitors patient deterioration through vital signs, heart rate, breathing, oxygen, blood pressure, mental status changes, respiratory distress signs. And understanding these patterns enables early intervention. So have a look at the chart, which will give you an idea about how the scoring system goes. Now, recognizing common deterioration patterns and the News 2 score is important. If I were to go to a ward, I'll always check what the News score for the patient has been and what is the trend. So trend is equally important. So the score is 0 to 4, clinical risk is low, ward-based response is sufficient. If, red score of 3 in any individual parameters, urgent ward-based response, and the clinical risk is low to medium. Aggregate score, 5 to 6, would be key threshold for urgent responses. Okay, the clinical risk becomes medium, and that's where, at 5 is where the sepsis screen happens. Aggregate score of 7 or more, it's high, urgent or emergency response. And that's where most of the hospitals have the rapid response team or the acute care team call-outs happening. Okay, let's go for the next one. Right, so any hospital you walk into or get a job or you start with, so know the deteriorating patient pathway and inquire and try to understand what is the pathway in that hospital. So the provisions usually in place are that there's a medical alert call-out. And as you can see, News 5 or more, you do a sepsis screening. News 7 or more, that's where, it's high-risk patients. You seek senior medical review at that point. And then if they go for a respiratory arrest, advanced airway team, they go for a cardiac arrest team. So that's how the plan usually goes, okay? And it's always good to step back and think, what is that I can offer? What are my limitations at every state, Let's go for the next one. Common referrals to ITU. The 5 H's I see as the common referrals to ITU, at least, a DGS level ITU. Hypoxia, hypotension, which includes all the forms of circulatory shock, head and neck issues, and when I say head, it means confusion, convulsion, coma, and neck issues like airway issues. H+ abnormalities, which could be acidosis or acid-base imbalances, metabolic or respiratory, okay? Which could also include alkalosis, so metabolic acidosis, alkalosis, respiratory acidosis, or even alkalosis, which is rare. High risk of organ failure. So if any patient is at high risk of impending organ failure, then that would be a referral reason for, or a reason for referral to ITU. Right, okay, let's go for the next one. So what would be a structured approach to a deteriorating patient, This would be as I see it, as I practice it. History, start with history, focus history, including cardiorespiratory reserves, or I would even think through cardiorespiratory, renal, hepatic reserves, and frailty score. That'll give me an idea about, the physical reserves of the patient, okay, and organ reserves as well. And examination with monitoring and IV access, standard ABCD framework, and use the hot mess framework, which I'll talk you through. That's something I picked in during the course of my training. And investigations, blood gas counts, chemistry, blood sugar, imaging, point of care ultrasound. So those are standard investigations. Do not forget things like, toxicology screen where relevant, pregnancy test where relevant. I see these things, sometimes getting missed. So be sure these are thought through. And then coming to diagnosis. So differential diagnosis and arriving at a working diagnosis, and rule out the time-sensitive ones first. That's how you approach, towards a diagnosis. So you approach towards a working diagnosis, but rule out the time-sensitive ones first, and work through a systematic differential diagnosis. Then comes management. So very important that the patient and the family are involved. Set the expectations right and the plans in place for care. And this is quite important. A lot of complaints that I come across are because we fail to do this properly. If you set the expectations right, which means, and define what will be the plan of care and document it, and then it makes a big difference, and you hand over it appropriately. So that really helps maintain the continuity of care. And, it avoids all the confusion and problems that comes with, miscommunications. So very clearly document clinical management and escalation plan as well, including you should consider the respect forms. So have very clear plans here. Now, let's go into history, understanding organ reserves. So organ reserves determine a patient's capacity to handle medical interventions and influence treatment planning. So what do we really usually ask for?
It's 18 hours.
Cardiorespiratory capacity and exercise tolerance, something we commonly ask for. Renal and hepatic function baselines, we would go through that. So does the patient have CKD? Has the patient taken an AKI on top? History of liver cirrhosis or, repeat hepatitis. And even don't forget the pancreatico-biliary tree. So often we may stop at just cardiorespiratory reserves, but it's a good idea thinking through the whole system. Musculoskeletal strength and mobility. Same muscular reserves are very important when you consider patients for long-term ITU stay or ventilations, because they are likely to get wasted and they may not be able to recover to reasonable functional activity. And overall frailty assessment. The frailty scoring is another thing we will do. These baseline organ reserves significantly influence the treatment decisions and help predict how a patient responds to various interventions. Now, in history, understanding organ interdependence, including medication effect, is quite important. I would give you an example here where imagine you have two patients and you have one ITU bed. So then how do you approach this? And you want to refer a patient to me. And both deserve, you should obviously refer both. But the way I will look through it is, when you refer to me, is suppose one patient has infective exacerbation of COPD with AKI on CKD, and the other one has infective exacerbation of COPD, and the gases are quite similar. I may prefer to take the one with AKI on CKD along with the infective exacerbation of COPD. And my reason would be this patient is likely to decompensate faster. So that's the importance of knowing, the different reserves of different organs and understanding their interdependence. There are quite a few other ones that you can look at. Chronic pulmonary, or cardiac pulmonary connections are there, and hepatic pulmonary, or portal hypertension. Hepatic dysfunction can lead to portal hypertension. Essentially, it can cause portopulmonary hypertension, and that could be poor outcome. And then hepatorenal syndromes. So there are multiple ways that one organ failure can affect the other one. And another common one would be the cardiac pulmonary connection. LV failure leading to increased pulmonary venous pressure, causing interstitial edema, reduce oxygen diffusion capacity, and can precipitate respiratory failure. So you see, knowing the reserves is very important, and then thinking through their interaction is very important, and what is that you have in front of you. It's not just as usually a single organ failure. It could be multiple organ failure, and at different thresholds, which are already sitting at different thresholds. And so it'll be hard work, getting them back to where they were. And you don't want them to start decompensating or failing, organ failing irreversibly. So that's how we would think through this. Then understanding how the medications are interacting with your situation is important. Imagine somebody is in hypotensive circulatory shock and has got sepsis on board. And the patient is on medications like ACE inhibitors, beta blockers, anticoagulants, and the kidneys are shutting down, the liver is shutting down. They are likely to accumulate and give a lot of trouble, and they're likely to accumulate. They may have their own toxicities, and they will affect the physiological functions. Like, somebody is hypotensive and you got ACE inhibitors accumulating. It'll just cause the blood pressure not to respond to your treatment. So that's something you should always think through. Medication, looking through. And very important that the Parkinsonism medication, anti-Parkinsonism medications are continued in patients. And you have provisions for optimizing medications in discussion with pharmacy where appropriate, especially when they have organ dysfunction. Right, okay, let's go. Examination, standard ABCD approach. I don't have much to say. I'm sure all of you are aware of this. And but what's important is do it properly and thoroughly. The reason is there are times when people have done airway, breathing, circulation, some form of disability examination with exposure. But the problem is with exposure could be incomplete. There are situations where people have missed bleeding in cases of circulatory shock. It was hemorrhaging, and could have been picked up if the patient was exposed. Even necrotizing fasciitis has been missed. That's what we see. Or ischemia of the lower limb. I've seen such cases getting delayed in recognition. That's because we have not exposed fully. So exposing a patient fully when they have, these deterioration is quite important. The hot mess approach would be a systematic approach, a framework for immediate intervention and assessment. See, you're called to do, or you're engaged in ABCD approach, and that usually, has all these steps. But the hot mess approach is something that I picked up during the course of my training, and I thought it's pretty good actually. So call for help, which I'm sure you'll build it up along with your ABCD approach. Oxygen, again, that may be thought through during your ABCD approach. Tilt, that's something the patient is not in arrest. You're likely to, give them a head up tilt or in a recovery position or pelvic tilt in pregnant patients who are, more than 20 weeks. So that has relevance. So, and establishing monitoring, that's something even you do during your ABCD assessment. You may establish continuous vital signs monitoring and documentation, and IV access, and then you send blood sugar, blood gas count, and chemistry. That's what you do. So can you see the hot mess approach is a good one, so you don't forget the key things. And about investigations, they are the essential tools to guide our assessment of patient conditions and inform treatment decisions. So blood gas analysis, blood sugar, and then comes blood cultures, blood counts, and chemistry. And then comes ECG and imaging. And I'm sure these are standard ones, but avoid forgetting them, and do not forget specific ones like MLA's toxicology screen or pregnancy test as appropriate. Let's move to the next screen. Now, for when you have a deteriorating patient right in front of you and you work through systematically, I would always ask myself, if it's me, I would always ask, what is the kind of care that I can offer this patient? What is the kind of care this patient will benefit from? So usually they fall under, these four generic terms: resuscitative care, supportive care, definitive care, or palliative care. So resuscitative care will be standard, resuscitation, fluid resuscitation, cardiac resuscitation. Supportive care, it's all about organ support, and that's where intensive care comes in. Intensive care essentially brings a patient for supportive care and try to help the body heal itself and recover. And then the process of weaning happens in intensive care to help them recover and come out of all the supports. And definitive care, like surgery, or as example in sepsis, if somebody has a central line which is infected, obviously the definitive care will be taking out the central line. Now, palliative care, if there are patients who are not responding to treatment or not likely to benefit from all unnecessary interventions, treatment intervention which are not likely to benefit a patient. If you understand that, if you think you're convinced about it, that's where you could potentially consider supportive, some form of comfort care or ward-based care, comfort care, or palliative care. And ideally, these decisions are best taken in discussion with the palliative care team. So just like the supportive care is taken with in discussion with the intensive care team, and resuscitative care, if they're in ED, you do a resuscitation there, or in ward, you do definitive care like surgery in discussion with the surgeons or the specialist concerned. Okay, let's move to the next one. Even in emergencies, see, you'll have a lot of competing interest while you're interacting with patients and your colleagues, and within that heavy charged atmosphere, whether it's one patient or multiple patients or busy ward. But I think certain things, if we keep in mind, it just avoids a lot of problems for ourselves, and we often come across well. These are not definitive or prescriptive, but these are things that I do follow. Okay, and so carefully balance multiple critical dimensions that extend beyond just medical treatment. So I think through these 3 or 4 layers, clinical layer, legal, medical legal layers, ethical, and then other contexts, like other contexts. When I say about cultural backgrounds, you have to be sensitive to them, gender specific considerations, and religious beliefs, and then about setting expectations with the family. So that's you have to be sensitive to all this. So the way I think through is clinical, am I clinically on the correct side? Legally or medical legally, am I on the correct side? Ethically, am I on the correct side? And these contexts, am I on the correct side? Or at least make an effort. If I'm not sure, I'll ask somebody else or try to seek expert opinion in these areas. Good. Let's move to the next slide. Now, coming to the spectrum of organ support, so it's very important to understand, realize that there's a spectrum of problems with the organs. The problems usually are, it's progressive, like somebody comes with angina, they may go on to develop an MI, they may go into cardiac failure. So similarly, you should know what kind of organ support you are able to provide as the scenario unfolds or as a scenario progresses in a deteriorating direction. So you should always be mentally prepared, and you should know what are the limitations of where you're working and how much is that you can provide, and what is the scope for escalation, and when will you trigger an escalation, when will you refer to a nearby center or a specialist center. So that's very important. So thinking through respiratory support, a simple thing I would say is, what is that you can offer in the ward? It may be just patient is hypoxic, probably you may start with a nasal cannula, you may move on to a Venturi mask, you may put on a Hudson mask, you may move on to a high flow or rebreathing mask, and then you may move on to ask for a CPAP in ITU, you may ask for an IV in ITU, you may ask for invasive ventilation in ITU. Maybe you think the patient is beyond that. If you're an ITU SHO, you may think about the need for an ECMO, or even up to transplants. You have to think through the full spectrum of support you can offer as the spectrum of the problem unfolds in a deteriorating direction. So the reason I'm highlighting this is I've noted that there are moments when people do not know what next, and then they may lose that continuity. And these are very dynamic situations. So thinking through the kind of supports you can provide is very key. Okay. And similarly for the cardiac and for renal and hepatic, you have to think through all the kinds of support you can provide. Okay. I would really like you to read through these areas and think through what are the supports you can provide within your working environment. And if this patient were to deteriorate for any system, what are you going to do next? Obviously you'll call your consultant or you'll call your registrar, but even before that, it's a good idea knowing that, when to call them and what you call them for or what to discuss. Right, perfect. Okay, let's move on to the next one. I'm not going into further discussions here. Now, I have used this, I mnemonic for systematic evaluation. Most of the conditions when they are, any patient who's a deteriorating patient or critically unwell, I run through these I's. It could be an infection, inflammation, immunity issues, autoimmune or immunodeficiencies, injury issues, physical trauma or tissue damage, ischemia, iatrogenic, idiopathic, and infiltrative or infectious, which means secondary complications or primary infections. So have a method to quickly evaluate through this, because if you know this, you will work through the labs and you'll send the right things to the labs and so on. So essentially you're working through your differentials very well using this. So even imaging, so you think through this. Using this approach, you're likely to go through all the relevant tests and escalation or imaging and so on, but have a method for yourself. Now let's look at the spectrum of problems that you come across. Let's look at the renal system. So essentially they fall into renal, pre-renal, renal, or which is intrinsic renal or post-renal. Pre-renal problems are primarily affecting blood flow and pressure. So essentially the volume and pressure are the primary problems here before reaching the kidney. Often due to dehydration or poor circulation, that's a reason often. But have a very generic, simpler approach to remembering these, and so that your recall is also so good. Renal, the problems could be glomerular, affecting the kidney's filtering unit; tubular, damage to the tubules that process the filtered blood; interstitial, vascular. So that's where your AKI screen. If you look at the AKI screen, it's actually looking at each one of them. Essentially you're looking at, evidence of glomerulonephritis or nephritic syndrome, nephrotic syndrome, tubular damage. You may look at evidence of tubular damage. You may look at microscopy for interstitial nephritis. You may look at vasculitic screens and blood films and so on. Okay, so just to give you an idea how to process this, So I don't see them as extremely complex, but it all depends upon how we feed that information. Post-renal, obstruction or blockage occurring after the kidney, such as in ureters or bladder. So sometimes simple catheterization will tell you, or doing an ultrasound of the bladder will tell you, or you may end up doing a CT-KUB, and that will tell you if there's any obvious obstruction. So let's go for the next one. The spectrum of cardiac problems. Okay, the way I usually approach this is, it could be a mechanical problem, it could be a vascular problem. It's best to think cardiac as cardiovascular problems, okay? And within that, think of the coronaries as well. And then, or electrical problems. So if you think like that, then it's very easy to, process, easy to approach these various topics. So I've written down the information, that you could potentially read and understand. But you have a cardiac problem, the way to think would be, is it a mechanical problem? Is it a vascular problem? Is it an electrical problem? And I should have probably said spectrum of cardiovascular problems. So look at this. It could be, imagine mechanical problem, could be at the valve level, could be at the ventricle level, it could be right ventricular, it could be an LV problem, left ventricular problem. And then vascular, just imagine it's a PE problem, or it's a aortic stenosis or aortic dissection, or aortic aneurysm rupture, And then comes even or coronary dissection, coronary vasculitis, obstruction, thrombus. So then electrical problems, it could be any form of conduction issues. It could be an AV conduction of issues, or connection through the branches, bundle branches. So, and so that's really, really important, and these are electrical problems will give problems with your rate and rhythm. So it's a good idea thinking through them like this, and that eases your cognitive load. That's why I'm telling you this. Again, for the liver, just like we went for kidneys, pre-renal, renal, post-renal, we can think through prehepatic conditions, intrahepatic, and posthepatic conditions. I've stated all the relevant ones here. This is just to help you, think through these the spectrum of liver problems that you face. But what's important is not to forget the pancreatico-biliary tree. So do not forget pancreatitis, gallstones, cholecystitis, cholelithiasis, choledocholithiasis, and CBD stone, and that also has got to be considered. So hepatobiliary, think of the whole hepatobiliary system rather than just the liver. So often what I notice is that people may forget to send amylase, or they are not found through the sepsis arising from the gallbladder, and especially if your patient is unable to speak, or you don't get adequate history, then these are things that one could potentially miss, and there's a delay in scanning or imaging for source control, then you may miss on things. So you see how many conditions could be picked up by early imaging if you suspect. So clinical suspicion is key, and then imaging is very important as well. Okay. Respiratory problems, I think the way I approach respiratory problems is, either it's a ventilation problem, perfusion problem, or a diffusion problem. Okay. So ventilation problem, I've just put the, examples over here, like neuromuscular weakness, airway obstruction, chest wall disorders. Perfusion problem like pulmonary embolism, pulmonary hypertension, cardiogenic shock, or diffusion problem, causing pulmonary edema, interstitial lung disease, acute respiratory distress syndrome. Or somewhere in between, sometimes you have ventilation and perfusion problems. So you call ventilation perfusion mismatch. So, and then, at one end, if you have perfusion or no perfusion, but there is ventilation, you may call it no perfusion, but ventilation. What do you call it? A dead space. So no perfusion means dead. So dead space. And the other extreme could be there is perfusion, but no ventilation. That would be a shunt. And the shunt, remember, could be intracardiac or extracardiac as well. So don't, so the respiratory shunts are possible, and something worth thinking about when you have, especially, oxygenation issues, and you have to think through these possibilities as well. So think through primarily ventilation, perfusion, diffusion problems, or pure ventilation, is happening, but there's no perfusion. That is dead space. Or on the other hand, there is perfusion happening, but no ventilation. That will be called a shunt. And anything in between would be called a ventilation perfusion mismatch. And diffusion problems, that's also got to be thought through. And I've told you all the potential diffusion. So you know how to manage it. Imagine somebody comes with is a COPD. And these are things we see. COPD patient coming with severe bronchospasm, which is acutely triggered, and patient has been having increased fatigue over the few days. Sometimes they're developing LV failure. Some form of LV failure has happened, and that'll trigger that fluid in that alveoli or interstitium is good enough to trigger the severe bronchospasm. And imagine this patient now goes for AKI on top. Do you know how fast they will deteriorate? And if you're still thinking it's just a ventilation problem, probably there's no cardiac problems. Always think of all these organs together, cardiorespiratory, renal together. And that really helps you address these kind of complex cases. So see, if you thought through the potential of a cardiac, so always rule out cardiac problems, even when you're working on a respiratory case, and then ensure the kidneys are not at risk. Kidneys almost like I almost believe it's like a fuse that goes off, and then the whole body just collapses around it, or other organs collapse around it. So be very careful with these complex scenarios. Okay, you really have very little time. So imagine elderly 80-year-old coming to with infective exacerbation COPD, and then is not producing urine, the blood pressure is slightly on the lower side. Actually, that's your probably last chance to salvage that patient, because these elderlies they are likely to drop their mean arterial pressure, and as a consequence, perfusion to the kidneys could go off, and they're usually on the hypertensive side as they get old, and they require their autoregulation ranges have shifted to the right, which means they require a higher mean arterial pressure in order to perfuse their kidneys and deliver the oxygen so the kidneys function. If this is not happening properly, because the heart is not functioning very well, or imagine there's previous right heart strain and right heart failure, so the oxygen is unable to travel across from the left side to the right side across the kidneys very well, and the kidney was so important in maintaining the pH, and suddenly that's knocked off, and the patient will deteriorate very fast. Even 1 hour of hypotension or 2 hours, it could be quite bad. And if they go into acute tubular necrosis, then it takes quite a few weeks to, for the kidneys to recover, the tubules to recover, and or they may recover partial function. So it's quite a step back. And kidney injury, AKI, is an independent predictor of mortality, up to 20%. So my real aim when I deal with respiratory cases, cardiac cases, or even renal cases is that they don't go for established renal failure. And I don't know how many people would agree to that, but I'm sure people practice this. And let's go to the next one. So which organ is likely to fail first? The answer would be the kidneys, and that's why. And the reason is because of the autoregulation range of blood flow. Kidneys are like a filter, isn't it? Situated farthest from the heart, and therefore they require higher MAP, or mean arterial pressure, to perfuse and deliver the oxygen. If they don't get it, they're likely to fail. And the normal blood pressure range, MAP range, mean arterial pressure range for kidneys is around. So it's H-shaped, but it's not 80 to 180. It's 70 to 170 MAP. Okay, and brain would be second most sensitive. Autoregulation range is around 65 to 130. The brain, if you think it's six-shaped, can you think of it as a six-shaped? And is 65 to 130 millimeter mercury MAP. Heart is 5-shaped, 50 to 150 MAP. So you see that your patient comes to ED, or you discover a patient in the ward who's really poorly, and they are hypotensive, the MAP is around 60, or the systolic is around 80, and the diastolic was around 65 approximately, with a heart rate around 120. And you notice that they're going oliguric first. You do a blood gas, the pH was fine initially. You saw the base deficit was around -4. Normal range would be around -3 to +3. And then you notice that the base deficit is creeping up gradually on subsequent. And that would be, where would that acidosis be coming from? That deficit of bicarbonate. Where is that base deficit coming from? It's likely from the kidney. And always look at the lactate. And if in doubt, do the ketones as well. So these are the common things other than toxicology. You see that? So these are the common things which will cause your base deficit to climb up, and it will contribute to the pH deteriorating as well. So, and you may not do that urea and creatinine that day, and it'll be slow to show up, and therefore working based on urea and creatinine may not be absolutely right, especially in the initial stages. A simple blood gas and the low blood pressure is good enough for me to ensure that I try to optimize the renal perfusion. and the oxygen delivery to the kidneys. So that's where I will intervene, quickly. I will take the patient to ITU, or do as much as possible in the ward to get the MAP right for the patient. It's not always 70 to 170, though we put the autoregulation range. We can't be very prescriptive about what is appropriate for a patient. There are patients who do very well even at a lower mean arterial pressure without the organ deteriorating. So those are things meant for ITU level observations and interpretation. So now your patient was getting oliguric. Suddenly you notice this patient is getting very agitated. You do a blood pressure cuff. You do a blood pressure, and you notice that the blood pressures are pretty high. So, and that could be a pitfall. So every situation, try to know the pitfalls. For everything that you do in medicine, I would always say, try to understand what the pitfalls are. And that comes with experience and with a lot of practice. And you'll always think through these. So the pitfall that I notice is when I go to see a patient who's agitated is somebody's doing a blood pressure, it'll come up high. And actually, the cell perfusion may be low. The MAP would be low. So kidneys have already started failing, and now it's the brain which is failing. And the biggest mistake we can do at this point is give something like a haloperidol or benzodiazepine to calm down the agitated patient. And then they go into a sudden cardiac arrest. So I'm not saying this is always true. Imagine the patient cannot express and they are in pain, and they may get agitated or something else, a cumulative effect of some medication affecting the brain. So you have to think through these possibilities, okay? And it takes time to reach there, but I'm sure you will all reach there in course of time, and reach there very early. So about the heart. Now, the last thing, nature has preserved the heart, and it arrests at the end, when none of these, the body is unable to compensate and the MAP is persistently low. And these coronaries, if you really do any bit of cardiac anesthesia or surgery, I'm sure you will see what's interesting is these coronaries are pinholes basically. they are easily occluded, and they're very pressure dependent flows basically. And the pressures are really poor, and especially if they have underlying coronary artery disease or so, which is known or unknown, then it could put them at a high risk of having ischemia, MI, cardiac arrest, and so on. Right, okay, let's move on to the next one. Now, there are a few very key themes that you need to understand, or principles that you need to understand. Oxygen delivery, cardiac output, and principles of regional blood flow. That's what I'll try to say here. But I think these are, I'll give you a very generic approach, very brief. You can read into the details of these. Like, if I go see a patient who's hypotensive in ED, I'll always systematically work through this. So I've done my ABCD, history, examination, investigations, and I've done the help, oxygen tilt, established monitoring, IV access, and bloods. And I'll look at the blood gas quickly and look at the blood results. And I'll look at the blood gas to see what the PO2 is, what the saturation of the hemoglobin is, and what the hemoglobin is. That just tells me the oxygen content is fine, Imagine the patient is in hemorrhagic shock, then the hemoglobin will be low. So I picked it up so straight. And what is the treatment there? Source control. You don't want to lose any time. It is source control, just like sepsis. So you have to occlude the vessels, or controlling the source of bleed. So then comes improving cardiac output. Second step is I will look, okay, it looks like the oxygen content is fine. Is the cardiac output fine? So systematically think through the formula for cardiac output, which is stroke volume times heart rate per minute, which is actually per stroke. Let me just show you. Per stroke, what is the volume that's ejected out, and how much is the heart rate per minute? So that gives you a minute volume that flows out from the heart. Okay, it's a minute volume. For respiratory system, you say a minute volume, tidal volume into respiratory rate per minute. Here, you don't call it a minute volume, you call it cardiac output. Okay, and these are things that I notice that youngsters need to remember. And the stroke volume will depend on preload contractility and afterload. So I'll quickly look at rate and rhythm. Is there anything that I can optimize in a patient who's hemodynamically unstable? Go by the ALS protocol. Maybe, imagine the patient is having arrhythmia, rate or rhythm issues. Is going to affect the cardiac output. So, tachycardic, arrhythmia, tachyarrhythmias, whether you need to treat it pharmacologically or you need to treat it electrically. So you think through that possibility. And sometimes you may have to intervene very fast to optimize the cardiac output. Then you look through the stroke volume. What's the preload? What's the contractility? What is the afterload? It's difficult to judge this, without using an echocardiogram. So meanwhile, before you get an echocardiogram, my simple questions would be, so have you given a preload? Which means, have you given any fluid boluses? And what was the response to the blood pressure? Response of the blood pressure. And so that's something, I will always, is the patient fluid responsive, fluid unresponsive? That really tells me, or how much fluid has been given. These are my key questions to understand. What is the preload and how is it functioning? So if a patient is hypotensive, it's not a rate or rhythm problem, then I'll think through stroke volume components, the preload, contractility, and afterload. And how much preload has been given is one of the questions. Are they preload responsive, unresponsive? If they are preload unresponsive, the way I would think through it is, this could be a problem with preload deficit still, still they are in a big deficit, likely, that's a possibility. Or it could be a contractility problem, or is there an afterload problem? You see that? So under those circumstances, I'll ask for ECG, echo, BNP, tropi. If in doubt, I'll probably work through thoroughly the cardiovascular system to ensure it's not, if it's anything more than that, so you don't miss out anything. Now, then once this is done, imagine I've given the fluid and I've done the echo, and now I want to improve the blood pressure. Or I've done a point of care ultrasound instead of an echo. That's fine. Now I'm doing I'm looking at the blood pressure. Still the blood pressure is not right. So I'll go to the formula of the blood pressure, which is actually blood pressure is a product of cardiac output and peripheral resistance. I've optimized the oxygen delivery. I've optimized the cardiac output, but peripheral resistance I have not touched. Okay, so peripheral resistance is like imagine your garden hose. You're watering your garden, and then if you squeeze at the end of the garden hose, it'll increase the pressures. So very similar. So there is a flow, and then you have to optimize. You could potentially optimize by increasing the squeeze, and that'll raise your blood pressure. So how do I do this now? Sometimes we start empirically, just without, we just go start some peripheral metraminol, or we take the patient to ITU and put a central line and start some NORAD. That's how usually you manage this deterioration. But there is another way to do it. If you're in doubt, you can always start a cardiac output monitor. There are non-invasive cardiac output monitors in intensive care. They are advanced monitoring basically. So which actually, if you feed in the blood pressure, it's able to estimate the cardiac output. And using the estimated cardiac output and the blood pressure, using the same formula, it's able to calculate the peripheral resistance, and it'll tell you the peripheral or systemic vascular resistance, and it'll tell you if it's high or low, and then you decide to go up or down on the NORAD. So there is a way of doing this, and that's why ITU becomes very important, okay, in somebody's fluid unresponsive hypotension, and the need to move them up quickly. Right, and then comes improving regional blood flow. Look, you optimize the oxygen delivery, you optimize the flow or the cardiac output, and you improve the pressure, okay? So you improve the oxygen content, you improve the volume and the flow, and then you have improved the blood pressure, okay? Now, does that guarantee there's a flow across the kidney or another organ? No, it doesn't guarantee, because the flow is dependent upon the pressure gradients, okay? P1 minus P2, and inversely related to the resistance. So if the resistance of that organ is high, the flow will be less. And, so imagine an intracranial bleed, and the cranium is boning fixed, basically, it doesn't expand. So if there's a bleed there, the resistance will be high, and even if you optimize all these components, the flow may not happen because the organ vascular resistance is high. And so your P1 here is the mean arterial pressure normally, and P2 is the central venous pressure or compartment pressure. Okay, now to ensure there's a flow, you have to ensure the components are all working or fine. So you have improved your MAP and your P2, which is your CVP or compartment pressure. Imagine the patient has a tight abdomen and the kidneys are failing, very tight post-laparotomy. So it could be a compartment pressure which is causing that kidney to fail, okay? So how do you ensure the blood flow so you work through this whole formula up to stage 3, but still the kidney is not picking up. And so what you could do is you could decrease the P2 by opening the compartment, okay? And then the flow will improve. So, or do other methods to decrease the P2, the abdominal compartment pressures. So that's the importance of knowing the abdominal compartment pressures or any compartment syndrome. For that matter, any compartment syndrome. Even the brain and the tight skull, the same principle applies. Or even coronary blood flow is slightly different. You don't talk about the P1 is not the P1 is not the mean arterial pressure, rather the aortic root diastolic pressure, and P2 is the left ventricular end diastolic pressure. Because if you look at the LV, the aortic root from the coronaries arise from the aortic root, and the opposing pressure will be from the left ventricular end diastolic pressure, because these coronaries line the epicardium. So flow is equal to P1 minus P2 by resistance. In that case, it will be it's not MAP minus CVP, rather it's aortic root diastolic pressure, because the flow to the LV occurs during diastole. Aortic root diastolic pressure minus left ventricular end diastolic pressure divided by coronary vascular resistance. So now, if you want to improve the blood flow, you can think about pharmacological intervention. You can think through radiological intervention. You can through surgical interventions. Okay, and that would be like let's look at the R, or you can use GTN, you can use thrombolysis, you can use angioplasty, you can use what else, bypass, coronary bypass surgery, and so on. So that's giving an example of how to improve the resistance. And so I believe I've covered, and I hope it's not very complicated. Just keep to these basic steps and try to pick up your understanding and knowledge about how blood flow to different organs. Right, okay. So understanding cardiac output and its determinants is very important. So cardiac output is a product of stroke volume and heart rate. Okay. So now, to help you understand, I can give you a scenario where somebody is in ED and who's got acute cardiogenic pulmonary edema. That's a known case of heart failure as well. And you are called into the scenario. How will you manage? So same history, examination, investigations, do all the interventions, and then you try to optimize the cardiac output. And you go through the formulas, and you can do a blood gas, find out what the oxygenation deficit is, what the pH is, and then how do you improve now? So what are the factors you can optimize? It will be the larger question. So go back to the formula. Blood pressure is a product of cardiac output times peripheral resistance, and cardiac output is a product of stroke volume and heart rate. So rate or rhythm is something I'll look quickly. Is that something, is a patient is having some abnormal any arrhythmia or tachycardia syndrome, severe tachycardia, severe bradycardia, or so on. So rate and rhythm is something I would really look first, because they are, again, time-sensitive ones is what you look straight away. Okay, then you look at stroke volume. So this is about optimization. Okay, so stroke volume, you look at the preload, contractility, and afterload. So preload, I would potentially see how much fluid has been given or no fluid has been given. I'll verify the amount of fluid that's given, and then I would look through. I'll probably ask for a quick echo under these circumstances, because the blood pressure is on the lower side, like just 80 systolic, and patient in cardiogenic pulmonary edema. Then I would consider, my key things to address here would be the rate, rhythm, get it addressed. Then I would think about contractility. See, it's difficult to do preload optimization. How do you do preload optimization when somebody's blood pressure is very low? Because it's likely to bring it down even further. How do you do preload optimization? Probably give a diuretic, open the tap, and decrease the stretch on that myocardium. So I'll probably squeeze the heart to increase the contractility so that it generates a better blood pressure. And meanwhile, verify this not afterload related. Imagine patient has some kind of severe aortic stenosis and so on. So that's how I would think through this. Okay, so that's just to give you an idea about how to think through various scenarios. And but a very systematic approach really helps you. Now imagine a patient is in hypertension, 220 by 110, and the patient is in pulmonary edema. How will you manage? You'll try to optimize the preload. You won't give fluids under these circumstances. You would rather take away fluids. So you'll open the tap using some diuretic. Okay, so that's your preload optimization. You decrease the stretch, and then that'll bring down the blood pressure slightly. And you can't do much about the contractility there. You won't give an inotrope under those circumstances, and you'll see if you can reduce the afterload. There's a need to reduce the afterload, like giving arterial vasodilators and so on. Within preload, you can also consider, things like using GTN, so pharmaceutical interventions, or furosemide, GTN, morphine, and those are things you can give. If they have pain, any form of pain, then that needs to be reduced. So you can give morphine, and morphine, reduce the heart rate, reduce the venous tone. That also contributes to reducing a preload. So that's how I would think through these scenarios. Okay, so this understanding of basic physiology really helps you to process things very quickly. Okay, perfect. It's not complete. Okay, let me say these are very complex topics. I'm trying to give you an idea about about these management, what principles to use. That's all I'm trying to tell you here. And so please read and look at all standard protocols for management. So again, preload contractility, they are interdependent in determining cardiac performance. For example, a high preload increases stroke volume but can lead to congestion-like conditions in heart failure. High afterload reduces stroke volume and increases myocardial oxygen demand. Enhanced contractility can compensate for increased afterload or reduced preload up to physiological limits. So those are the principles which go into managing these LV failure situations with hypotension or hypertension. And these concepts are obviously very fundamental in managing conditions like heart failure, shock, and hypertension. So MAP, mean arterial pressure, they represent the average blood pressure in arteries during one complete cardiac cycle. Formula is MAP is diastolic plus 1/3 of pulse pressure, which is systolic minus diastolic. Normal range is around 70 to 100. More representative of organ perfusion pressure due to longer diastolic phase. The heart rests mostly in diastole. Therefore, and the formula, as you see, it's more represents the diastole. So it's considered the driving, MAP is considered the driving pressure, therefore. It's a critical indicator of organ perfusion, and minimal threshold is around 65 millimeter for adequate vital organ perfusion. Below 65 millimeter mercury risks tissue ischemia and multi-organ failure. So serves as both diagnostic tool and therapeutic target in circulatory shock. The example, I can give you some examples in management of different types of shock. Septic shock, they use norepinephrine or vasopressors to maintain MAP above 65 millimeter mercury. Hypovolemic shock, you give fluid replacement to restore preload and cardiac output. And cardiogenic shock, inotropic support to improve cardiac performance. So we usually target MAP in ITU because we got the arterial lines very easy. And I'm sure the non-invasive blood pressures also demonstrates MAP. So it's something worth looking at. If you haven't seen it, if you haven't observed it, they're very helpful. And working with MAP is quite helpful. But I would say they're very reliable when you have an arterial line in place. That's why if it's tricky, they need ITU. Okay. I find shock index very fascinating in the sense I've been able to find so many cases where, or observed during mortality reviews, I find the shock index was high, more than 1 for at least 12 hours, 24 hours before they finally have a cardiac arrest. Patients have a cardiac arrest. So look at shock index. It's a simple bedside tool to assess hemodynamic status and risk of shock. So normal range is 0.5 to 0.7, and more than 0.7 indicates hemodynamic compromise. And so simple way of looking at it is, if you see the heart rate above the systolic BP, and especially where the systolic BP is on the lower side, you see that? That's a bad sign. You know, so be very, very smart in detecting this from a big distance. You can look at a screen from a distance, and then you can look at this from a distance on any screen, and then you can detect this very fast. Recently, I had a patient who would come for a normal operation, a simple small operation, but blood pressure was 94 systolic, and the heart rate was 124. So a bit surprising, that doesn't fit. He's absolutely fine patient, young, reasonably fine patient. So didn't know why this is happening. So I said, do a ECG, where ECG was not even indicated in that case. So do an ECG. The ECG showed ST elevated MI, ST elevation. Not sure whether it's an MI. So I rushed to the cardiologist to discuss. He said, I'll do a bedside echo. They did a bedside echo, and he had an LV aneurysm. So he probably had a recent MI, and this LV aneurysm was responsible for those kind of changes on the ECG, and so shock index could be helpful. I would not have picked it up unless I have thought through shock index, and now I keep using it more and more. So please consider it, and it's not a very standard utilization, but I don't see everyone using it. But I really think, after doing a lot of mortality reviews, I think shock index is a good one to observe and use. And it'll give you early ideas about, and it's very simple. You look at a chart and the heart rate is above the systolic BP and the systolic BP is on the lower side, then you better take care of the patient quickly, address it. So this is not absolute, okay, but it's a fast, reliable, and early indicator of shock severity. That's my thought. Understanding peripheral resistance. So blood pressure is a product of cardiac output and peripheral resistance. Obviously, there are, its definition, is there, but primarily determined by arterioles, and they are the primary resistance vessels. And if you just think of your garden hose. When you squeeze the tip and the flow is reasonable, then you notice that the pressure increases. So that's what this is about. Blood pressure is a product of cardiac output and peripheral resistance, and so you give something to squeeze and increase the peripheral resistance. So if you give a pharmacological agent like metramidol or NORAD, they tend to increase the peripheral resistance and increases the blood pressure. That's why we take cases of septic shock quickly to ITU, so that we can you work through the whole thing that we have been discussing, and then we start some NORAD with cardiac output monitoring to increase the peripheral resistance, okay, and increase the mean arterial pressure and increase the perfusion of organs, therefore increasing the oxygen delivery to the tissues, and that's really saves the day. Okay, so I'll give you a case study. Elderly patient with hypotension, clinical presentation of low blood pressure, requiring assessment of shock type and appropriate medical response. So 82-year-old sick patient presented with complaints of abdominal pain and respiratory distress. Blood pressure 80 by 45, heart rate 120 per minute, saturation 78% on air, respiratory rate 32 per minute, catheterized, low urine output 10 to 15 ml per hour for the last 2 hours. You've been called in to see this patient in the ward. Let me say it's a ward now, okay? Now, interventions, you quickly go on through the new score, which is on the higher side, around 7, and you ask for ABG, and you've done your help, oxygen tilt, established monitoring, IV access, send bloods, and everything is done. You've done a full ABCD systemic examination, and then you notice the blood gas, and you send the blood cultures, biochemistry, everything has been sent. And ABG shows pH 7.25, PO2 7.6 on air, and base deficit is -7, lactate is 4. Now, what's happening here? Now, what's important is, again, you go through your systematic approach. Let's see, what is the systematic approach? There are further details for this patient. As you can see, this is in the ward. patient come from ED, there's a missing period, then patient has come to the ward, and that's where you're picking up this patient now, okay? Temperature is not high at this point in time, and respiratory rate is 22. I think the previous one I said 24 or so, but irrespective, this is what the scenario is, okay? Respiratory rate has gone up from where it was. Now, how to approach this case? How do you manage this case? I think go back to the structure, history, focus history examination, including, all the cardiorespiratory reserves, cardiorespiratory renal reserves, frailty scoring, and examination with monitoring and IV access, ABCD, hot miss approach, and investigations. You send the blood gas counts, chemistry, blood glucose, imaging, point of care ultrasound. Diagnosis, you work through differential diagnosis and try to arrive at a working diagnosis. Rule out time sensitive ones first, okay? And then you piece together your management plans and discuss with the patient. Family is very important. Set your expectations, set the expectations of the patient and the family very clearly in place. Help them understand these could be dynamic scenarios, which means, there could be a roller coaster ride with these problems, and it'll take a while, and how serious it is. So state all those, and clinical management and escalation plans. Make it very clear here, okay, in your management. So obviously the blood pressure is low, lactate is up, and what are your initial thoughts? So very important to say the terminology, use the right terminology, okay? Because the patient is in circulatory shock, probably, to come to that conclusion, you have to find that the patient's, it doesn't always have to be hypotension, but the rise in lactate with fluid unresponsive hypotension points towards it, okay? There's evidence of other signs of poor perfusion, and compromised circulation is also important. And then sepsis, there's evidence of query infection and evidence of organ failure. The kidneys are almost shutting down, plus the lactate is rising up. I think I would go in favor of sepsis. And but rather than jumping into it, I'll probably have a thorough workup. Okay, I'll discuss it later. And then if you think there is a likely source, if you've located a source, or you've thought about the possibility of source, you have to identify, you go for imaging and try to find out the pathology or likely pathology, and then you escalate as appropriate. Or even if you doubt, you can always give a surgical call out and so on. And so that's how I would work towards a diagnosis. So sepsis, recognition and managing, you will immediately tell me, do sepsis, I'll do sepsis 6. So obviously sepsis 6 is not, I think, I don't know where it came from, but it's finally made its way into all the learning. But I would say there are problems with it that we need to know. Okay, I'll discuss it here. So sepsis is 10% mortality. Septic shock is approximately 40% mortality. Okay, and so you would tell me I'll give oxygen if required, which is improve oxygen content if needed. Agree. You would say measure lactate. What does it show? What is it for? Essentially, we are trying to look at oxygen delivery issues. Are there any oxygen delivery issues or oxygen utilization issues? And it also shows the response to resuscitative measures. It gives us an idea about oxygen delivery, response to resuscitative measures, fluid resuscitative measures, and so on. Obtain blood cultures, which you would do, and not just blood cultures. I think if you think there's a risk of chest infection, I think you do a full workup, cultures, viral swabs, urine culture, and so on. Okay, then you administer antibiotics. It's usually done. All this is usually done within 1 hour. Okay, then begin fluid resuscitation, or it happens simultaneously, which is nothing but your preload optimization. You will catheterize, which is monitoring renal function and adequacy of the resuscitation volume and pressure. It gives you an idea about the volume, resuscitation, and the pressure as well. Okay, whether it's the end organ is being perfused or not. If the kidney is getting perfused, it's likely that the other organs are getting perfused. So, and source control. That's one thing. If you look at the sepsis 6, I think all that gets covered, but source control is often not thought about, which is, I believe, it's one of the most important things. And as a result, I see a lot of junior doctors stopping at 6, but not thinking through source control. So I would request you to think through source control. Don't forget source control in sepsis and bleeding. Even bleeding, you do everything, but if you don't think about the source, controlling the source of bleed, then it would result in problems. So, and eighth one is optimize volume and pressure. That's what you're trying to achieve. So you're trying to optimize oxygen delivery, you're trying to optimize volume and pressure and preserve the organs and ensure you have blood cultures and antibiotics. This is what you're trying to achieve. So it's a good idea thinking that, have I optimized, asking yourself at the end of it, have I optimized the volume and pressure? If you can't optimize the volume and pressure, then you better call ITU, because you won't be able to do it. You're limited in your ward environment or even ED environment. So call intensive care. So differential diagnosis of shock. So circulatory shock is something that you see very commonly. As I said, people get referred to ITU for the 5 H's: hydrogen ions, hypoxia, hypotension, high risk of organ dysfunction, and so what else? I think most of these conditions are head and neck issues, head being confusion, convulsion, coma. So these are the reasons that people usually get referred to ITU. Okay, so and within circulatory shock, you should be thorough with circulatory shock because it's a killer, and the circulatory shock precedes organ failure and death. So always do a systematic assessment of circulatory shock. Now you have been empowered with all the knowledge underlying physiology for you to understand how to salvage a patient out of circulatory shock. And when assessing shock, always think through cardiogenic, septic, or distributive shock. It should read distributive shock, which includes septic shock. Everything is distributed because the peripheral resistance is low. You see that? Go back to the formula. Blood pressure is a product of cardiac output and peripheral resistance. If the cardiac output is depend upon stroke volume and heart rate, stroke volume depend on preload, contractility, afterload. If it's a preload issue, then it's likely hypovolemic shock. Can you see that? If it's a contractility issue, it's a cardiogenic shock. If it's a obstructive will be different. Obstructive will again can cause a preload, especially if there is tension pneumothorax or tamponade, and which is again results in a form of obstructive shock. Yeah. So then comes septic shock. Blood pressure is a product of cardiac output and peripheral resistance. If peripheral resistance gets affected, that's likely a septic shock. It's distributive in form. So there are many kinds of shock which can happen. It need not be just septic. Just imagine anaphylaxis. If it's anaphylaxis, yes, it could present as a septic shock. It could be like that, and or neurogenic shock. Spinal anesthesia or epidural, and they could be in a distributive shock. So that's very important to know. Okay, and then endocrine related causes of shock. Please do not forget that. Even there is something called dissociative forms of shock, which is carbon monoxide poisoning and cyanide poisoning. So endocrine related shock, please do not forget. Like imagine somebody has diabetes insipidus or Addison's crisis, meningitis with Addison's crisis. Imagine those kind of situations. So always think through endocrine causes of shock as well. Otherwise you'll miss, okay? Or patients on chronic steroids and didn't have the steroid doses. So avoid assumption, evaluate all potential contributing factors, determine the appropriate treatment approach. What happens if you leave circulatory shock for long? So they go through different stages, pre-shock, early warning signs and initial deterioration happens. In pre-shock, they're in a compensated state. See, if it's elderly on like beta blockers, they may not be able to compensate. They may straight away slip into shock and early organ failure. The youngsters are likely to remain in pre-shock state for a long time. And if you see that, especially the shock index or anything like that, in a young patient, don't miss it. Don't leave it for long, because they'll end up with shock and organ failure. We don't want that happen. And it is an independent risk of mortality, these organ failures. And they move into shock when they decompensate, okay? and then they go into organ failure, and finally, it's a terminal outcome if left untreated. So it's very important to decide, are you going to treat it conservatively? Are you going to treat it actively? And how do you want to manage this? You've observed this. I would stand there, ask, is this patient for resuscitative care? Is this patient for supportive care? And is this patient for definitive care? Or if none is applicable and the patient is likely to not respond to treatment, aggressive treatment, then is this patient for palliative care? So those are the questions I'll ask myself. Okay, perfect. Pitfalls with fixation of sepsis. I would say do not miss these conditions: MI, PE, pancreatitis, stroke, CCF. Look, sepsis by definition is a life-threatening organ dysfunction caused by a dysregulated response to infection. Sepsis and septic shock are major healthcare problems affecting millions of people around the world each year, killing between 1 in 3 and 1 in 6 of those it affects. Sepsis mortality is 10%, septic shock 40%. There's no one biochemical test to diagnose sepsis. So your clinical suspicion is key, okay? Imagine you don't suspect, then you're likely to miss sepsis. As a consequence, what you notice is there's always an overdiagnosis, okay? But in the overdiagnosis, there's a risk of missing MIP, pancreatitis, stroke, CCF, because they all result in some kind of, the systemic inflammatory response syndrome, which is the 4 T's, 2 out of the 4, it's considered a systemic inflammatory response. I'll go through it. Tachycardia, tachypnea, temperature, up or down, above or below the normal range. Total leukocyte count. So if 2 are positive, total leukocyte count above or below the ranges. And which, if these 2 out of these 4 are positive, is a systemic inflammatory response. So be careful with, these conditions. So if you need a 12-lead ECG, BNP, TROP-I, echo, or MLAs, and or stroke team's input, go for it. Don't if you doubt, but please learn to doubt. And for everything that you learn, always think about the pitfalls as well. That'll change how we process information. Now, recap: approach to a critically ill or deteriorating patient. Always check the latest news score, shock index, I would say, and ABG, and then check these before you even talk to others. But always work through the time-sensitive ones. Could it be a STEMI? Could it be a stroke? Intracranial bleed? Intra-aortic, intrathoracic, or intracranial trauma? Airway at risk? Necrotizing fasciitis? AAA leak or aortic dissection? Status epilepticus? Sepsis? Fluid unresponsive circulatory shock? Emergency surgical cases? Example, ischemia of the gut or limb? Sickle cell crisis, and others. Okay. Now, does the patient have any other common critical features? We have already discussed this: hypotension, hypoxia, hydrogen ions, head and neck issues, high risk of organ failure, and others. Now, you will look at the, with me, I'll definitely look at what are the reserves and comorbidities, help understand the risk and rate of deterioration, identify which organs have decreased functional reserves, okay? And then I would usually go for a quick discussion, decision, and documentation, okay? Patient wishes and priorities considered, next of kin or relatives discussion, surrogate decision makers, advanced decision making, respect form, limitations in place. We'll work through all that, okay? And or one of your team members. It doesn't mean it's just one person doing this. And then what's our plan of management? Are we going for resuscitative care, supportive care, definitive care? And if palliative care, then we have to discuss with the palliative care team. And there could be various pathways for them. So then the question would be, have I optimized medications and fluids? Like in sepsis, you would give around 30 ml per kilogram. Have I done that and observed a response? And have I optimized the medications? Have I considered relevant imaging? Have I considered appropriate referrals? Finally, I would like to ask myself, what's my working diagnosis? Or with the team, it doesn't have to be just you. So be very open, and you may be limited in various circumstances. So feel free to discuss with other team members. So like if I'm in intensive care, I'll openly discuss with the surgical or a medical team or endocrine or cardiac team. So I'll ask ourselves, what is the working diagnosis? What are our differential diagnoses? Determine with the consultant the appropriate level of care. If you're a junior, determine with the consultant what would be the appropriate level of care. Any doubts, conduct quick MDT approach. Consider reversibility, reserves, and best practices within that discussion. Document key reasons for referral or escalation to ITU and state management plans. So often we get patients, but then we don't have a clear plan for future. See that? So this is something that we would always encourage, especially our junior doctors who could contribute to that place, Anyhow, key takeaways. Patient survival depends on rapid recognition, systematic assessment, and coordinated team response. Every minute counts. Early recognition saves life. Know your warning signs. Follow structured diagnostic approach to avoid missing critical conditions. Understand your limitations and escalate care promptly where needed. Remember, circulatory shock always precedes organ failure. Intervene early in the disease progression. Build evidence before making clinical premature assumptions. So no assumptions in medicine. I will keep saying this. So try to be very, very objective in your approach. There are moments when you require a subjective approach, but try to find the evidence for it, within your workup. And most of the cases who are dying, what's interesting is they go through a state of circulatory shock. So circulatory shock or early signs of circulatory shock, treat it as a warning sign, and then really dig into that case to understand what's wrong, what's right, and what you can do, and what are your limitations, and so on. Yeah. So I would recommend that you read the applied physiology in these areas, cardiac output, blood pressure, blood flow, autoregulation of blood flow, oxygen content, oxygen delivery, ventilation, perfusion, dead space and shunt, shock index, and news 2. These are the suggested websites. Derange Physiology, excellent one. MedMastery is a very good one, but it's paid. Obviously, NICE has got these. Always read NICE recommendations and guidelines, and then you can. That's very important. I would say it's very important to read NICE guidelines. So make it a habit. Start as a junior. And so, any questions? Anyway, I'm far away from you at the moment, but I'm sure you'll have questions. Obviously, our questions could be clinical, conceptual, or practical questions. Make it a habit in any teaching or any interaction. Sorry, my cat is making all the noise. It's a lovely one. So ask about specific patient scenarios and medical conditions. Clarify understanding of key principles and approaches, and discuss real-world applications. And try to understand the root principles basically for everything. That really helps you have a very good method of approaching complex scenarios. So I've improved like this by using a lot of mind maps in my life, and that really helped me understand that they were all interconnected. Everything is interconnected. Hey, thank you all for being here and listening to my teaching. And I'm a cat person promoting Marzil, who's a lovely Bengal cat. Okay, good. Thank you guys. All the best.